Initiative for Health, Accountability and Transparency welcome you to Continue Professional Development course on Primary Healthcare Renewal for Optimal Performance. This is Module 4 on Sustainability Challenges in Primary Healthcare Intervention Programs. The outline of this presentation will include introduction, and this will cover definition, objectives of intervention programs. We'll also do case studies and discuss issues and challenges in the intervention programs, look at sustainability problems and the sustainability elements, the determinants of sustainable health system. We will also speak about sustainability barriers and look at the findings and discussions on our case studies. We'll take some lessons learned and look at recommendations for securing sustainability, and we'll draw some conclusions. On completion of this module, participants will be able to explain the meaning and importance of sustainability in primary healthcare intervention programs, describe some PHC intervention programs in Nigeria, explain the issues and challenges in the intervention programs. Participants will also be able to explain sustainability problem and its elements, describe the determinants of sustainable health system, and also describe sustainability barriers. Primarily, the most fundamental objective of the health system are to improve the health status of the population by lowering mortality and morbidity rates, and also to respond to the citizens' health needs and demands. Primary healthcare special intervention programs are implemented when existing and continuing approaches are deemed insufficient to have beneficial impact on the health concerns. They are commonly implemented in multiple settings using multiple strategies and are most effective when large number of people are reached. In many settings, these interventions are inspired by the desire of governments and development partners at various times to build a better health system for the people. In Nigeria, primary healthcare intervention programs have multiplied over the years, with international health development goals providing the greatest momentum. Remarkable examples of the international development goals include the PHC Health for All, the Millennium Development Goals, and most recently, the Sustainable Development Goals. The universal trust is that intervention programs are designed to address inequity and inequality in access and health outcomes. One of the core values of primary healthcare approach is spirit of self-reliance and self-determination, implying that primary healthcare is based on the cost that the community and country can afford to maintain at every stage of their development. This element is the key to sustainability. Sustainability is viewed in the context of self-reliant health system with capacity to function effectively on continuous basis. However, often than not, intervention programs do not have capacity to function effectively on continuous basis and therefore do not automatically become part of routine implementation, and thus raising the issue of sustainability. What is an intervention program? Intervention programs come and go. A primary healthcare intervention program can be defined as a combination of program elements or strategies designed to improve health status of target population. Health sector in Nigeria has witnessed intervention programs designed to fill the critical gaps in strategic choice areas in the health system. This model is conceived to provide insight into sustainability challenges and lessons learned in select public-funded PAC intervention programs in Nigeria. In many instances, many high-profile programs interventions have failed to guarantee sustained capacity, that is, continuity and self-reliance in service delivery. At the center of these concerns is the issue of sustainability. Looking at 3 case scenarios. The first is we'll look at the PAC infrastructure expansion project, which was designated as the World Health System. We'll also look at the Midwife Service Scheme, MSS, and we'll also look at the Subsidy Reinvestment and Empowerment Program, MCH, what we call SureP MCH. Participants should note that there are other equally important donor-assisted intervention programs. We have strategically chosen these public-funded programs against the background that sustainability challenges are only common in donor-assisted intervention programs. Let us take a brainstorming exercise. We have just mentioned 3 public-funded intervention programs, but I want you to list 3 donor-assisted intervention programs you are familiar with. We'll start with PAC infrastructural expansion under the World Health System. There have been multiple primary healthcare infrastructural renewal over the years. They have been primarily programmatic. The emphasis here is that they have been more or less programmatic. Looking at PAC infrastructural expansion, the centrally funded PAC infrastructure expansion presently under the National Assembly Constituency Intervention is one of such programs. It started as an integral element of the World Health System initiated in 2001. It was designed to develop a community-based health system around model primary healthcare centers. The intervention consists of model primary healthcare centers to be built in carefully selected target areas. It also includes supply of equipment and seed drugs to improve physical access to essential services. Like I mentioned earlier, intervention programs happen in multiple settings and also involve multiple strategies. The construction began with construction of 201 model PAC centers in the world that have no health facilities. It had other elements such as the World Health Grant of 1.2 million, community mobilization, and capacity building were embedded. It is to be noted that the members of the National Assembly adopted the intervention as constituency project in 2006. By 2015, a total number of 1,469 model PAC facilities have been initiated, with only 792 representing 54% completed, and out of these, only 435 representing 55% were fully operational and functioning based on the established guidelines. The second centrally funded project is the Midwife Service Scheme. The MSS is an MDG's Debt Relief Grant centrally funded high-profile intervention program. MSS became operational in 2010 in response to poor maternal, child, and newborn health outcomes in Nigeria and the slow progress on the MDGs 4 and 5. The focal point of the intervention was the deployment of midwives to carefully selected health centers supported with basic maternal and child health equipment and essential drugs. The midwives were paid monthly stipend of 40,000 naira by the federal government and was expected to be complemented with additional 10,000 naira each from the state government and the LGA, while the community provided accommodation based on subsisting memorandum of understanding. Other elements of intervention were multiple trainings on life-saving skills, integrated management of childhood illnesses, and the linkage to the general hospitals as referral facilities. There was also support with ICT for data management, deployment of community health extension workers, community mobilization, and management support in form of monitoring, supportive supervision, and mentoring. At its peak, there were about 4,000 midwives and 1,000 community health extension workers in 1,000 PAC facilities that were linked to 250 general hospitals serving as referral facilities. It was made up of a cluster, and the cluster was based on a hub and spoke strategy, where you have one general hospital linked to 4 primary healthcare facilities. By 2012, the MSS intervention has become a health sector flagship program that was much admired, winning local and international awards and improving maternal and child health, service utilization, and outcomes across the beneficiary facilities and target areas. The successes and the international awards became strong justification for the expansion of the intervention to cover more beneficiary facilities and communities. Incidentally, this period coincided with the introduction of subsidy reinvestment and the empowerment program SureP in 2012. Unfortunately, rather than to simply increase investments in the intervention, to expand its scope, a parallel maternal and child health component of SureP was created, and there comes the SureP MCH. Thus, MSS became constrained by inadequate funding, resulting primarily from reduced funding from the regular budget to the extent that payment of salaries, essential medical supplies, and trainings became Herculean task. Let us look at the third case, and this is the case of subsidy reinvestment and the empowerment program, maternal and child health, which was designated as SureP MCH. SureP MCH intervention was designed to be a rider on the Midwives Service Scheme that was already seen as a great success. However, it did not operate on the existing governance system of the MSS, but under a separate project management unit. SureP continued with the core elements of the Midwives Scheme, but had an expanded scope. Additional elements included infrastructural renewal of the facilities, staff quarters were also built, ambulance services were incorporated, and a demand-side intervention where conditional cash transfer was designed to stimulate demand of services. At its peak in 2015, SureP had 3,811 midwives and 3,133 community health extension workers and 5,966 village health workers in 1,000 primary healthcare facilities linked to 250 general hospitals as referral facilities. It is to be noted that because the midwife service scheme had started experiencing challenges, particularly with respect to payment of salaries, some of the midwives, or majority in number, migrated to Suape MCH. The program was terminated in 2015. It is widely reported that less than 2 years post-Suape in many facilities, the midwives, community health, extension workers, the village health workers, which constitute the core element of the program, were not retained. The gains in the area of availability of qualified manpower, access to quality maternal and child health services, and essential drugs had started to fritter away. What are the cross-cutting issues and challenges in the three reported cases? Issues and challenges reported in the implementation of the three intervention programs can be discussed under the following. We have the contextual factors, which has to do with political and economic matters and unsuccessful collective approach. We also have inadequate consultation and lack of collaborative planning and implementation with the states and the local governments. And we also have the default in MOU implementation. There were issues with implementation of signed MOUs by the states and local government. Other contextual issues include lack of ownership. Quite often, there is the failure of states and local governments to assume ownership and fulfill their obligations, including unwillingness to deploy human resources and supply of essential drugs to new FGN facilities. This is with respect to primary healthcare expansion projects in which model health centers were built. These model health centers were seen as federal government of Nigeria facilities, and the states were reluctant to deploy manpower and also provide necessary supplies and logistics. There is the poor alignment with established standards. Sometimes the appropriations do not align with the established national minimum standards for primary healthcare. The minimum standard for primary healthcare construction was type 1, 2, and 3. But since there is usually no adequate consultation between the National Assembly members and National Primary Healthcare Development Agency, the appropriated funds sometimes do not align to allow for establishment of these facilities in line with national minimum standards. There is the issue of appropriation factors. The late annual budgetary cycle was a significant impediment to all interventions. Usually the budget cycle do not start in January. There's also the issue of late fund releases, resulting in insufficient time for implementation. For a project that is planned for, say, 2018, and for the funds to be released possibly in August, September, usually it's a great obstacle to completion of the project. And finally, there is often the issue of mopping of unspent funds, little or no appropriation at all, particularly when you have new representatives at the National Assembly for ongoing projects leading to abandonment, because the new members do not see the project of their predecessors as their own, even though it is a project for their constituency. There are also political and community factors. Political consideration may have dissuaded the embedding of Suape on the MSS. It was designed to ride on contributing to the stifling of the midwives service program. There is the interference politically in the other implementation processes like site, facility selection, and this often affects the execution of intervention projects. On the issue of community factor, In many instances, communities do not agree on the location of the primary healthcare intervention programs, leading to significant delays. And sometimes there are issues of insecurity in restive communities, and this also impairs continuity of intervention programs, including retention of health workers. What are sustainability challenges? For many years, sustainability was perceived as the donor's dilemma, mostly because it was seen as a serious threat to institutional credibility. The concept, therefore, revolved around the continuity and success of external investments. However, the concept is beginning to gain interest and visibility in public investments in intervention programs. Based on the core values of primary healthcare, sustainability is viewed in the context of self-reliant health system with capacity to function effectively and on continuous basis. Sustainability is about triple elements, and this includes efficiency. Efficiency deals with effective service delivery. It also includes continuity, which deals with functioning on continuous basis. It also deals with self-reliance, which deals with capacity. We need to understand the key elements of sustainability to be able to have informed insight on sustainability challenges. Efficiency. Efficiency revolves around access to health services of good quality and also health services that addresses the health needs of the population. We have continuity, and this deals with long-term viability of an intervention program, providing long-term and continued access to quality health services and also meeting people's health needs and health status improvement. There is the element of self-reliance. Self-reliance means ability to address one's own needs. It requires ability to effectively transform resource inputs into health inputs over time. What are the basic requirements for self-reliant? Two types of capacity are necessary. Financial, that is the capacity to obtain sufficient resources locally, and functional, capacity to use the resources effectively and efficiently over time to meet health needs and demands of those intervention programs are meant to serve. Let us look at the twin capacities of self-reliance. The financial capacity implies absolute level of local resources are available and the ease with which the resources can be secured and how the resources are employed to sustain basic levels of services. And the functional capacity implies capacity in policy making, planning, organization and management of health system that enable effective and efficient use of available resources over time to meet health needs of the populations. Having gained some understanding of the elements of sustainability, what are the determinants of sustainable health system? I have adopted a systematic approach based on health system development process to examine sustainability in the intervention programs. there are two factors that determine the shape and direction of health system development process and outcome. And these are the contextual factors, some we have already highlighted earlier, and the investment factors. What are these contextual factors? The environment which surrounds the health system directly and indirectly influences its survival and effectiveness. Sustainability is not a problem rooted in financial constraints. An enabling environment is also a key to sustainability. There are external and internal environmental factors. They include political, which includes the laws, policies, and constituency for health, that is, the actors and the attitudes. It also includes economic, which has to do with capacity, the allocations, and consistency of resources. We mentioned earlier on the budgetary and appropriation challenges in terms of the quantity and timeliness and the mapping norms. And also, it also depends on organizational structures and actors which act on the health system. Let us look at the investment factors. Investment in health system is a key requirement for it to fulfill its functions effectively and continuously. It is akin to nourishment. The types of investments can be local or development assistance, or both in most instances. And it depends on the process, on the quantity and quality. The process includes the institutions and actors, the ministries, donors, the motives, the political leaders. It also depends on the methods of investments, the allocation, and also the budgetary management. The quantity has to do with the volume of investments. If it's not sufficient and adequate, certainly the intervention programs are likely to fail. And also has to do with the quality. The quality is based on how strong the accountability mechanisms are. What are sustainability barriers? Combinations of factors, not solitary elements combined to provide sustainability. However, barriers to sustainability of health interventions result from hostilities in environment, what we call the contextual hostility, and also investment process, unfavorable investment behavior, lack of budget orientation to primary healthcare services, and poor budget management practices like we mentioned earlier. Let us apply sustainability tests. We have identified what we call interventions sustainability indicators. And we have indicators on the right, and on the left side you have the description of these indicators. We have effectiveness. What it means is that intervention is functioning effectively based on project description, on continuous basis, improving access to services and also addressing health needs. We have continuity, and the description of continuity is long-term viability, continuing access to quality health services, and improvement in meeting people's health needs and health status. And we also have self-reliance as an indicator, and it means local financing by the states and local governments, and functional, which has to do with policy, organizational planning, and management capacity requirement is secured. There are other two indicators. We have the conducive environment, means favorable economy and political changes, and internal constituency for primary healthcare intervention program, successful collective approach, overall consensus by the federal government of Nigeria, the states, and local governments. And we need to ask ourselves, how successful was the collective approach with regards to all the three programs we have mentioned? There is also the issue of quality of investment, adequate resources for maintaining basic healthcare delivery operations, management support, drugs and logistics. To what extent were all these provided in the 3 programs we have described? Let us score these sustainability challenges with regards to the 3 interventions. We will score 0 for non-fulfillment of this description. And if there is partial fulfillment of description, we score 1. And with full fulfillment of description, we score 2. And this is what we have. Horizontal column, we have the indicators, the 5 we have already described, and you have the sustainability score. And on your right hand, vertically, you have the cases we have just mentioned of the intervention programs, the infrastructural expansion, the midwife service scheme, and the SureP program. And we have scored all of them 1, 1, 1, 1, which means there was only partial fulfillment of the descriptions of indicators. And then where there is non-fulfillment at all, we score 0. And you will see that with respect to self-reliant, it is 0 for infrastructure expansion and 0 for midwife service scheme, even though we have scored 1 for MCH SureP. Let us look at the sustainability score. All of them score 40%. What are the findings? Based on the adopted criteria, each of the 3 interventions scored 40%, indicating that none can be said to be sustainable. We are exploring the possibility of subjecting the concept to further research to give more in-depth insight to the issues that have been highlighted. Let us take discussion on the reported 3 cases, the drivers of sustainability, and these are synthesized from the reported challenges in the implementation. We have the drivers, and we also have the challenges based on the report on the 3 intervention programs. We have the contextual environmental factor. The environment which surrounds the health system poses significant threat to its sustainability. And based on the reports of the 3 cases, we have existing political and economic variables, actors and organizations, and program management capacity impacted negatively on these interventions, like we discussed earlier. The political interference, the economic and budgetary variables, the actors themselves, including the communities, the organization of the health system, particularly with respect to engagement between the federal, state, and local governments. There was poor collaboration with the key actors, political class, and other stakeholders, including the states and LGAs and other communities, resulting in the dereliction of expected responsibilities. Like we mentioned earlier, the MOU was implemented in breach. There are the economic conditions, public health allocation and spendings on the interventions were unpredictable, and the issues of budget circles, mop-ups, non-releases are all issues we have mentioned earlier. Apart from the contextual issues, the second driver is the investment practices, and the description is sufficient resources is required for capital development and maintenance of health system operations to stimulate improvements in the health system capacity and health status. And the challenges that were highlighted in the report of the 3 cases includes the intervention programs suffer from inadequate resources for both capital development and maintaining basic healthcare delivery operations. There were the issues of late releases of capital projects, mop-ups of unspent funds, even when the programs are ongoing. Lack of operational costs, including regular drug supply and logistics, were very significant challenges. What are the lessons that have been learned with respect to the three cases? Sustainability should not be viewed from donors' perspective alone. It is equally a critical challenge in public-funded intervention programs in Nigeria, like we have seen in the three programs. Lack of sustainability in government-funded interventions called for a new perspective in design of the intervention program. We had spoke earlier about ineffective collective engagement between the federal, state, and the local governments. To improve long-term viability, intervention programs must be designed in a way that promotes the development of effective, continuous, and self-reliant health system. Favorable political and economic variables alone does not guarantee sustainability. It is a function of combined favorable contextual conditions and good investment practices like we have discussed earlier. Ineffective collective approach manifesting as poor collaboration between the states, local government, and the communities is largely responsible for neglect of expected roles and responsibilities. Sustained intervention programs will require improvements in planning, management process, and budget practices, including providing for operating costs. Let us look at the recommendations for improving sustainability. The first is that there should be more focus on comprehensive strategy rather than programmatic approach. The intervention programs were not based on any comprehensive strategy but programmatic approach. In the federal health system, a state-inspired and driven but federal-supported comprehensive strategy with a multi-year plan would have guaranteed multi-year funding, enhanced the support of internal PAC constituency, and mitigated against political changes like we mentioned earlier, particularly with respect to members of the National Assembly. Build internal capacity both financially and functionally, and it should involve strengthening capacity for planning, organization, and management of health system that enable effective and efficient use of available resources over time to meet health needs of population, and consider direct budget support rather than top-down implementation, that is with respect to cooperation with the states. Build effective local partnership. The states and LGs largely see the interventions as federal projects. Local involvement should not be token. Engaging, supporting, and strengthening local structures in planning and management of intervention programs is very, very vital. Use of permanent local structures for implementation of health interventions is also very, very important. Rather than to use federal structures for intervention programs at the local level, we should shift towards using permanent local structures. Effective delegation of responsibilities, including resources to the states and local government health authorities, will be key to providing and sustaining operational costs. The conclusion is that PAC intervention programs are implemented when existing and continuing approaches are deemed inefficient to have beneficial effect on the health concerns. They are commonly implemented in multiple settings like we have seen, using multiple strategies we have also seen that, and are most effective when large number of people are reached. The universal thrust is that interventions are designed to address inequity and inequality in access and health outcomes, but often than not, interventions do not automatically become part of routine implementation, and this often raises the issue of sustainability. To improve long-term viability, intervention programs must be designed in a way that promote the development of effective, continuous, and self-reliant health system. Let us take this online assignment. Did the 3 donor-assisted intervention programs you listed earlier at the beginning of this module become part of routine program implementation? What factors contributed to their sustainability or otherwise? You are required to do online submission to be marked CPD-PEC assignment of not more than 500 words on the above issue to iheartnigeria@gmail.com. Our dream for a strong health system and better health outcomes will remain a dream unless we work for it. Working for it requires great understanding of the issues and challenges. Strong leadership, effective management, and transparent governance is the key to building an effective, accountable, and transparent health system.